I'm very happy to welcome David. Donc David Buckeridge, un collaborateur de McGill. Donc, ce qui est génial, c'est que j'ai découvert hier que en fait, ça pouvait être aussi compliqué de présenter quelqu'un, au moins qui travaille au Québec, par rapport à quelqu'un qui travaille en France. Parce que, par exemple, David, il est professeur à l'université de McGill dans le département d'épidémiologie, biostat et occupational health et médecine du travail. Et il est aussi Chief Data Scientist au McGill University Health Center, donc c'est l'hôpital. Et là, ils ont encore une autre couche, c'est donc je ne sais plus le titre que tu as à ce niveau-là, mais au centre de recherche du McGill University Health Center. Donc ça fait 3 affiliations, et ce qui nous ressemble beaucoup, voire 3. Et donc comme vous l'avez compris, donc en fait il travaille beaucoup en informatique en santé, mais c'est la vision Public Health Data Science comme on l'enseigne ici, avec vraiment aussi beaucoup de connaissances en épidémiologie et en statistique qui met en œuvre globalement pour répondre à des questions de santé publique. Ce qui est assez génial chez David, c'est qu'il se préoccupe aussi vraiment de l'impact en santé publique, et il se trouve qu'il a encore, mais ça va bientôt s'arrêter, une implication au niveau de la santé publique sur tout le pays du Canada, donc l'équivalent de Santé publique France pour l'ensemble du Canada. Et donc, il a une activité vraiment totalement translationnelle, de l'hôpital, en passant par la recherche en sciences des données, en santé publique, pour aller jusqu'à donc l'impact en santé publique. Et je me souviens très bien, la première fois, je suis allé à Montréal pour le programme, donc le joint programme qu'on fait avec McGill, donc entre ISPED et McGill pour Public Health Data Science. Quand j'ai rencontré David pour la première fois, je me suis dit, waouh, c'est avec lui qu'il faut qu'on travaille, parce que ça a tellement de sens par rapport à ce qu'on est en train de poursuivre ici à Bordeaux. Donc merci beaucoup, David, d'avoir accepté l'invitation. Et comme vous le savez peut-être, c'est aussi notre parrain de la promotion de l'ISPED cette année. Enfin, c'est des promotions de l'année dernière, donc pour la cérémonie qui aura lieu demain, vendredi, à partir de 17h. Donc merci beaucoup, David. The floor is yours.
Merci beaucoup, Rodolphe. C'est vraiment un plaisir I'll switch to English just because the presentation will be English, but very much a pleasure to be here and to be able to share with you some of my experience in the role that Rodolphe described. For the last 2 years, I was part-time with the federal government and the Public Health Agency of Canada, leading really an activity to build a vision for public health surveillance in the country. And so I'll talk a bit about that and the lessons that came out of that. And I'm going to illustrate some of the challenges and opportunities in the context of serosurveillance, which is an area where I spent a lot of time during the pandemic. So I've organized this into 3 parts. The first part is really to give you a sense of what that visioning activity was like, why and how we did it in Canada. Then I'll transition to describe a little bit of what serosurveillance is like in Canada, so you have a sense of the context and how that evolved. And then I'm going to bring those 2 threads together in the third part to use the vision to describe the steps that we'd like to be able to take, or I think we should be able to take with serosurveillance in Canada to move towards that vision. So starting with the vision, it's been released, and so if you're interested, there's a QR code that you can use to get access to the PDF, and I'll share these slides after if anybody is interested in that. But you know, we embarked on this. Actually, the Public Health Agency approached me and asked if I would take on this role. The title was Executive Scientific Director within their surveillance operations. And so this was really the main thrust. I also helped with organizing or trying to reorganize some of their data processes and infrastructure. But the idea here was that there really hadn't been anything done in Canada to build a sort of a direction we want to go in surveillance for the country for at least 10 years. As you may recall, we had a pandemic, and there were a lot of lessons that could have been learned, but there was a sense that they weren't really being brought together in a coherent way, and that we needed some kind of an effort to pull those into our planning process. And of course, the world's changed a lot in 10 years, both in terms of the things that should be under surveillance and how we can go about surveillance in terms of the methods. And many other countries had already done this and shown that it was beneficial for their planning purposes. So what was unique about this process is, even though it was led by and funded by the Public Health Agency of Canada, it wasn't an intent to create a vision just for federal surveillance. It was meant to be for the entire country, recognizing that, I'm sure it's the same it is in France, that surveillance happens at multiple levels, federal, municipal, regional, with many stakeholders involved. And so the idea here was to really be kind of a bottom-up process where we engaged with people doing surveillance, we looked at the science, what other people were doing, and we really tried to create something that was aspirational in terms of a vision, inclusive of all these partners, but not binding, because to create something that was really binding in a political sense would have required a very heavy process over many years, and was thought to be really non-viable. And finally, action-oriented. We didn't want to come up with a bunch of problems and challenges alone. We wanted to also come up with what we called opportunities. So how do we go about doing this? Well, we met with an awful lot of people. We had in-person consultations in every province and territory in Canada, and for those that have been there know it's a big country, so that involved a lot of moving around, 29 in-person consultations with public health practitioners, academics. And the Government of Canada also posted a online survey and had almost 1,000 responses to get input into where we should go with public health surveillance. And then we commissioned a number of different meetings and reports, including a rapid review of the literature I'll talk about in a second, literature reviews on other subjects. We also obviously summarized the discussions from all those consultations and had international consultations. All of that information led into a very large qualitative synthesis to identify and extract themes related to challenges and opportunities in surveillance. And then we had an expert roundtable that took that information and through a modified Delphi process, tried to really identify what the opportunities were to move forward. And we considered opportunities to move forward as things where there was feasibility, because we were seeing some motion in that area somewhere in the country, and they were deemed to have potential for serious impact. And I'll come to what those are in a second. This is just an example of the result from the rapid review around surveillance innovations. This is a Sankey plot, which you probably obviously can't read the little things, but starting from the left, it's sort of classes of things under surveillance. So the big gray bar is infectious diseases. As you can see, most surveillance innovations are in that area, even though we have a lot of challenges in chronic disease, obviously. The smaller gray bar, the next step is the more specific disease, and so COVID-19, of course, comes out very strongly because this happened as 5-year intervals, you'll see at the top, encompass the start or most of the pandemic. And then the next step over, you can see the areas, the methods that really came through, and I've highlighted some of them there. So starting from the bottom, there's obviously a lot of work in wastewater surveillance, which is still ongoing, and some debate about how that fits into the public health infrastructure in Canada. Genomic surveillance, digital surveillance, which of course Rodolphe referred to in terms of the digital health context and digital public health. And then of course point-of-care testing, which is a new methodology that's becoming more and more involved in surveillance activities. So those inputs led to identifying a number of trends that are really driving the future of public health surveillance. I don't think any of these will come as a surprise to you. The first digital transformation speaks to the need and the occurrence in many public health agencies to really change the way they do business from what's been mainly a manual and ad hoc approach into more of a modern process. Global health surveillance, I won't say more about that. That's pretty apparent that surveillance is no longer a local thing. You need to have a broader perspective to have awareness. And then new sources of data and tools, which are sometimes hard to separate because we have things like genomics and wastewater I mentioned that are both new approaches, but also generating new types of data. And serosurveillance could be sort of thought as a rebirth in some sense in that space as well. So these are the challenges. We call them persistent challenges because many of them you probably could have guessed before we even started this process, and we could as well, particularly the ones on the right. So issues around workforce competencies. Are we training people the right way to be able to do surveillance in a modern era? That is a challenge. Are we resourcing them? That's also a challenge. Data quality, access, and use is just a pressing and persistent problem in public health surveillance, certainly in Canada, and from what I understand in many countries. And the same for the strategic use of technology. And I'll come back to those a little bit in the last part. On the left, at the bottom, number 3 is something rather sort of particular to Canada in terms of our relationship with Indigenous peoples, which has not been positive. We're going through reconciliation and trying to come up with an approach to really be respectful of these populations, which really have a nation-to-nation relationship with Canada based on original treaties. And so how does that fit into public health surveillance is important. The second one sort of echoes WHO report that came out in the last year on collaborative surveillance, and really noting that public health surveillance is no longer can really be seen as a technical exercise that one agency does on its own. It really is something done in collaboration with the population under surveillance, both in terms of the data that are collected and the information that's returned to that population, and also with other stakeholders, and ideally with other surveillance systems, and I'll come to that more in a second. The first one was a bit of a surprise for us, but this is something that we heard consistently in our consultations with people who were doing surveillance, is that both within surveillance systems and agencies and across agencies, starting with within, people were often not always clear why they were collecting data and certain types of data, how it was being used, to what end. That whole sense of like understanding the value and the cycle of the data that are being collected. And then across agencies, and even within agencies sometimes, it's are we surveilling the right things? Public Health Agency of Canada has 63 separate surveillance systems. There are many more at the provincial level and the local level. When you look at the ensemble of all of these surveillance systems, are they really monitoring the things that are most important to us in public health? Most people would say no. So how do we get from where we are to there? And that's really a bit more of a governance aspect in addition to the purpose. Here's the vision statement we came up with, and I won't read it out for you word for word, but one piece that I think is relatively unique about the vision statement is this focus on not just single systems, but as I alluded to in the previous slide, the collection of systems. And we borrowed a term from systems engineering, which is systems of systems. And what that really means is that we think about independent systems, and this diagram you see on the left is meant to sort of be a systems of systems diagram. Each of those circles is meant to be a notional surveillance system, and you can see from the circle that's enlarged that cycle that we think about in surveillance of data collection, management, interpretation, so on, through to action or informing action and mobilizing knowledge. But those systems are operating usually in sort of sectors, so it could be at a provincial, regional level or national level. And we expect data to be, and information ideally to be exchanged between those systems and also between sectors. And on the outside we see the population, which is of course we're providing data into all these systems, and knowledge and information is going back out to influence these populations. So ideally these systems are working in a collaborative and coherent way, which is I don't think the case right now. And systems theory tells us that's not going to happen on its own. We need to do something to support the governance in terms of how these systems can work together, acknowledging that all of these systems, or most of them, need to maintain independence and need to be aware of a value proposition that improves their operations by interacting with other systems. So that's the sense of shared purpose. And then of course is the technical need for interoperability. And so this is I think a key part of the vision that we're looking at more carefully. How can we advance this to go beyond a bunch of individual systems into a more coherent system of systems? So as I mentioned, the challenges which I already described to you were kind of the problem statement, as it were, and are things that we understood and knew about to some extent going in. The opportunities you see on the right, and there were many opportunities that were identified, so these were the top 10 that came through that Delphi process. I'm not going to go through all of them, but I will come back to them later in the talk when I try and show how we can use this vision to think about how we can improve serosurveillance as an example in Canada. And so with that, I'll switch gears a little bit to talk about serosurveillance and experience in Canada. So some of you may be familiar with this approach to surveillance, but I'll just start with an overview for those of you that may not have as much background. I certainly was not as experienced in serosurveillance prior to the COVID-19 pandemic. It's thought of an approach that can complement traditional case-based surveillance in public health. It's not new. It's been used for decades, but there has been a bit of a renaissance or renewed interest during the COVID-19 pandemic. And if we move to the diagram on the side, you can see that it follows some of the usual steps in surveillance in the sense that you have to, first of all, sample some people from the population, and it depends on the approach you're taking, whether that's a random sample or a convenience sample. Once you have that sample, you then actually have to obtain blood from people, which can be quite challenging. Ideally venous blood, although dry blood spots can be used, but they have different characteristics. And then once you have the sample, you then want to test that blood sample for the presence of antibodies that are reacting to certain antigens. And then you essentially have a population at the bottom that you sampled. Some people are seropositive, some are seronegative, and that allows them to compute seroprevalence and other metrics that can be related to the force of infection in the population. So there's a number of challenges you might imagine in doing serosurveillance, or you might know if you've already been involved in serosurveillance. The first is how do you sample these people, and how do you obtain the blood? Very expensive sometimes, depending on how you're doing it. Then there's the laboratory infrastructure. And going back to what I was talking about before, when you think about how all these things fit together in terms of not just systems, but the platforms that support systems, ideally that you're doing it in a multi-pathogen way to make it efficient, because all the work you've done to sample the people who get the blood, ideally looking at multiple pathogens, or at least multiple antibodies. Then you need some kind of standardization if you're doing this in anything but a fully centralized way, both for the assays and the data. And of course, you have to be able to analyze and interpret the results. So these things can all be quite challenging in practice. So that cycle is, in its ideal form, is shown on the right in terms of steps that you would follow. And then on the left are some of the use cases that have been identified for serosurveillance in the context of public health. The first one is fairly obvious, to estimate the burden and distribution of infections, monitoring population immunity. It sounds quite straightforward, but of course, it can be challenging when you have infections or viral mutations over time, understanding what is truly happening in relation to the, translating seroepidemiology into an understanding of population immunity. You can obviously identify emerging and re-emerging infections. It's not the only approach. In fact, wastewater surveillance has also been shown to be quite valuable for that, but that's an important use case. Identifying gaps in vaccine coverage, assessing changes in exposure to MPIs or non-pharmaceutical interventions, and obviously in some settings, monitoring disease elimination goals. So in Canada, prior to the pandemic, we really had no routine serosurveillance systems operated by provincial, federal, or any level of government in the country. What we had was what I would call ad hoc seroepidemiology being done mainly through research studies, and then of course our two blood operators. We have one blood operator for the province of Quebec and one for the rest of the country. And so they were testing blood donations much more from a blood safety perspective than a public health surveillance perspective, although they've become, as you'll see, very important partners in how we think about using serosurveillance in a public health context moving forward. And there really was no coordination or standardization of the epidemiologic methods for creating the cohorts, for the assays, the laboratory methods or data analysis. It was really almost a very bespoke approach. Even when there were automated systems from major manufacturers, they were often implemented differently in different labs. And then arrived the pandemic. And early in the pandemic, Canada was actually fairly agile in getting out in front of this issue. A task force of scientists was created and obtained direct funding from the federal government on the order of about 200 million euros to put in place this task force with a mandate to generate information and knowledge about immunity to SARS-CoV-2 through serology for the most part. And that turned into funding for two types of approaches to doing serosurveillance. One was de novo designs, where investigators came forward and described how they wanted to do a seroepidemiological study, usually through cohorts that would create of different populations, for example, hospital workers, incarcerated populations, schools, for example. Or existing large cohorts, longitudinal cohorts in the country. We had cohorts on aging, cohorts on cancer risk, and so they were able to add essentially seroepidemiology or serology to existing cohorts. That generated about 200,000 samples for us over the course of the pandemic. And then we had residual bloods, which came from the blood operators I mentioned, and also provincial laboratories. So each laboratory has each province in Canada has a laboratory that receives samples of blood for testing, and they're able to retain some residual blood from those samples and do serology on them. And I have the numbers there. You can see 1.1 million samples came from those. So what's interesting is those two approaches were very complementary. The first set of studies really were good at sort of, I would say, addressing evidence gaps and doing research in the sense of understanding, generating knowledge, trying to look at really what do we know about immunology. The second approach was really well suited for surveillance. Because of the number and the consistency over time and space, it gave us the resolution we needed to really be able to follow the serological response to this infection in the population. So this task force was supported by a secretariat, which was based at McGill University and led by Tim Evans. Some of you may know Tim. And it had the job of obviously putting out grant calls, reviewing those grants on a very rapid basis, providing awards to investigators for these studies. Communications, so of course important to make sure that the public was well informed and other scientists were well informed. Data management analytics, which is what I led for this operation, and I'll talk about that in a second. And then knowledge translation. We had a very fast cycle of providing knowledge out to public health practitioners, including our chief public health officer on a weekly basis, and more detailed reports every month, really trying to describe the state of immunity in the population. So the group that I led and sorry, just to mention, that started in, I think the dates are probably a little hard to see, we started in April 2020 and formally wrapped up in 2024. But some of the data work has continued in the context of the data bank, which I'll talk about in a second. But before we get to the data, we had to address the issue of data governance. So we had on the order of about 100 studies that we funded. Many of them were prospective, some were already cohorts in place, but all were based, except for the residual bloods, which I'll come to in a second, were based on individual consent. And we really wanted to be able to get the data, the individual level data from all these studies and be able to share it for research in the future. And so that required very careful attention to the ethical and legal framework that allowed us to collect those data and then further share it or disclose it for research. So we were very involved in creating a data governance framework to outline that whole plan and approach, and providing guidance and consent elements to individual investigators to ensure their informed consent would allow them to share data with us and allow us to further share data with other investigators. And then, of course, we had to really work with each of these investigators or groups to actually deposit data in a data bank and share it. And that's a process that is actually still wrapping up, but we were very close to finishing that. So the data management itself required us to identify core data elements for all the epidemiological information gathered, data standards for the epidemiological data, the laboratory data, and then also to go through the process of supporting people as they formatted their data, deposit in a data bank. Then we would create metadata for all of those, harmonized data, so that they can be analyzed consistently, and then make them available through an open, then create open data sets, which I'll come to in a second, and then also make the data available through an online portal. And then, of course, we had to do analysis, and I'll talk a little bit about that in a second, and the reporting that I already mentioned. So the informatics and data governance really was a fairly heavy lift, I would say, in the process of trying to support all of that. And really, the challenge was trying to keep up with things. These things were moving quite quickly. Studies were out there. They were gathering data, and trying to get in front of that in terms of the data standards and making sure that the people were collecting data and sharing data in the appropriate format was quite challenging. But we were, I think, quite successful in doing that, and we've now published the metadata for virtually all those studies and the full data sets for the open data. I'm showing you the page for an open data repository that holds some of the open data sets, some of which have been downloaded more than 4,000 times, which shows there is interest in these kinds of data. We've noticed that even though we do have a lot of data available through the restricted data access mechanism, the individual level data, that requires investigators to make an application. There's no fee involved. But they have to have a protocol and ethics review, and so there's a bit of a barrier there to access. And so we are doing research on how we can create open data sets from those existing data, either through a de-identification or synthetic data generation. We actually have a qualitative study going on as well. So we have a postdoc who's doing a qualitative analysis of this whole data sharing exercise. What are the expectations? Did it work? The community, how did it come together? And then finally, we've been successful in linking the serology data from one of the blood operators to administrative records in the province of Ontario, which I'm very excited about, because that's 60,000 serology records linked to longitudinal data on vaccination, on infection, and healthcare utilization. And we'll have a number of research activities coming out of that. We also, as I've kind of mentioned in a few points, had to deal with issues in sampling and assay bias and how to adjust for those. So one of the main arguments for going with really well-designed studies is that you'll get representative data of a population because you can define your sampling frame and sample the people. And one of the arguments against going with residual blood is you kind of get what you get, and blood donors are not fully representative of the population has been the assumption, and residual bloods from laboratory testing, of course, are testing people who are, for the most part, ill, and not representative population. So because we had these data from multiple types of studies and sources, we were able to look at this question. And so what you're showing on the left is a paper that came out recently where we just created a simple concept of representation ratio. To what extent do we subdivide or stratify the populations in these studies? Are they representative of that subpopulation in the general population? So what was a bit of a surprise there is, in fact, residual blood from blood surveys, from sort of blood donations is actually quite representative. And in fact, some of the best designed, randomly sampled population stratified studies done by our statistics agency were less representative because of bias and response. So it was a little counterintuitive, but I think quite informative for how we might go forward with this kind of surveillance in the future. On the right is showing some of the work that we did in assay adjustment. So there are standard methods for kind of doing adjustment on just the aggregate data when you have seroprevalence measures and trying to adjust those for differences in assay performance, sensitivity, and specificity. They generally don't perform terribly well. So we develop more regression-based methods when you have some shared controls across the two assays that does a much better job at adjustment. And so showing that it's actually possible to use these different assay types if you have the ability to appropriately adjust them. The other area that we had to do some work in was in time series methods. So this is really, as I mentioned, trying to move from seroprevalence to some understanding of what that means for population immunity. On the left is one of the plots from an overview paper we did looking at the evolution of seroprevalence to SARS-CoV-2 in Canada. What you can see is the first very sharp rise in triangles is the anti-spike antibody, which is in Canada, all of the vaccines were only targeting the spike protein of the virus. And so when we saw a rise, an isolated rise in anti-S or anti-spike, it was clearly due to vaccination. And so we could use that difference between the anti-spike and the nucleocapsid, which is the other antigen that was looked at, to look at the difference between vaccination-induced immunity and infection-induced immunity. And so what you see is that first rise is the sharp rise in immunity related to vaccination. And on the right, you see the more slow rise that's related to infection in the population. And then we also took some of the learnings that we had from how we were applying the time series models in this context to a global scale. And that's showing a figure from a paper that we published together with colleagues of the World Health Organization to analyze essentially temporal trends in immunity through the UNITY studies, which were a series of prevalence studies done around the world in different regions. And really the issues there were somewhat similar to Canada, but different in terms of the quality of reporting that we had to adapt for. And then finally, I would be remiss to not mention the within-host modeling work that Rodolphe and I have collaborated on, really done by a graduate of this PhD program at McGill, the Co-Tutel program, Iris Ganser. And what she did was exploit these data that we came from the blood operators. So many people that donate blood repeatedly. And so we had, hundreds of thousands of people who donated blood, but many of them had tens, if not more, of donations. And so because of that distinction I mentioned between the spike protein, which is really we see a response to that induced by vaccine, and the nucleocapsid in relation to the infection, Iris was able to distinguish vaccination events and infection events in these individuals, and then translate that into two analyses. One where she basically used survival analysis to understand the waning over time of the protection essentially from these different antibodies, both the anti-N and anti-S. And in the second study was using mathematical modeling to really model the decay process of these different antibodies in the human. And what's showing on the left there is what you can see is at different thresholds, the decrease in protection. And over time from these antibodies, and in particular showing the difference between the number of infections you've had. So the bottom, the blue is the first infection, the darker colors are second and third infections, showing the value of hybrid immunity when you've had a vaccination, usually plus infection, and increasing your protection. Okay, so that's serosurveillance in Canada. So now I want to try and bring those threads together to describe really how we can use some of what I described in the vision to think about how we want to move forward with serosurveillance. So you'll see the challenges again on the right, and I've just kind of pulled out the ones that I think are perhaps the most interesting in the context of serosurveillance. First of all, if we step back and think about in a public health surveillance, operation at an agency level or a country level, how we use serosurveillance is a question. Really, how does it fit into all the different approaches and methods we have for surveillance? And what's the appropriate investment in this strategy? Because it's not cheap. You've got to have laboratories that are ready, you have to have the sampling, and you have to know which organisms or other things that you're surveilling for it's amenable to. And serosurveillance is not a magic bullet. It doesn't work for everything. So it worked reasonably well for SARS-CoV-2, but in the context of thinking about this, again, also, is this something for pandemic preparedness? That's nice, but we don't know what the next pandemic will be, except we know it's probably coming. And we ideally have something that's useful in an everyday sense in public health. So these are a lot of things to understand, like what's the right strategy here and how is the best way to deploy this technology in the context of other technologies. Then there's the question of data quality and access. As you may have guessed already or seen from what I said before, the best approach is really these residual bloods that we get access to, but they usually come with very little additional information other than serology results. So trying to interpret that is complex. For example, you'd really like to have some knowledge of prior infection, prior vaccination, comorbidities, social determinants of health, for example, things that would really help you to understand what's driving the infection in the population. And then, of course, as I mentioned, there is bias in sampling and assays, and we've done some work on that, but it's not like this is a solved problem, I would say. And then finally, how do you actually use your technology strategically when you want to deploy it? This goes a bit to those sort of smaller cohorts, which would be very targeted in subpopulations, very active if you think about that in the way surveillance versus passive, where we just wait for residual bloods to come at us and we test them. So those are the challenges. The opportunities, there are many of them. And I'm just going to, before I dive into those specifically, I'm just going to describe what we're proposing. And this is a number of people that were involved in serosurveillance in Canada have come together and proposed a network that will be based entirely on residual blood surveillance. That we think this is probably the best strategy moving forward. And if we focus on the blood operators who take blood donations and the provincial laboratories and some pediatric networks as well, because that's a population often missed by those other components, we can achieve 99.7% coverage of the population in the country. So that's pretty good. But there are still challenges. So I won't go through all the details, but we're proposing this kind of a nationwide residual blood strategy, and with the key piece being that it's a federated model. So these data are not being pooled centrally, as we tried to do in the CITF example I gave you, the central data bank. The idea here is to leave the data within each jurisdiction, and I'll get into that in a minute, what that means. So if we go back again to these challenges and opportunities, I'm going to focus then here on the last two challenges and the opportunities here that really map to that. So one is how we can enhance surveillance by integrating data on social determinants of health. And then the other ones relate to is data standards, more general data linkage, and modernizing our data infrastructure. So the first one, social determinants of health. As I mentioned, we had very little additional information on anything beyond serology, except for one of our blood operators, as I'll show in a second. But we know that social determinants of health are critical in driving who gets exposed and often who has negative outcomes from infection. And this is something that came through very clearly in our consultations too around the country when we were doing the visioning exercise, was that there was no consistent way to bring social determinants of health data into public health agencies and link to surveillance system data. Often it was only available at the area level and sometimes only at the very coarse area level. And so there was this sense that even though we talk in public health all the time about social determinants of health, we weren't really taking action on that in the space of public health surveillance. And so we think we have a good model for how that might work. And that's essentially through that federated process will allow us to, leaving the data within each jurisdiction, will allow us then to do that individual level linkage without, and that's allowable under legislation in Canada if it's done by the government in a secure manner. And of course, that can be then aggregated and used for surveillance. And so here I'm just highlighting what we know about this. There's two plots here, again, from the COVID-19 pandemic. The one on the left, the smaller one, is showing age distributions, which is fairly easy information to get out of the serology data, showing, of course, that the younger populations tended to have higher rates of infection here, although better outcomes. But on the right is really the only data that we could get which is really quite shocking for the entire country, on, and this was essentially saying were you white or not white, in terms of reporting in a very coarse way that was done in blood donations to the major operator in Canada. And we can see that non-white populations had higher rates of infection throughout the pandemic, which we assume is due to higher exposures, due to being in often jobs or positions that didn't allow them to stay home or avoid exposure to the virus. So, but this is a very coarse analysis. And so we think there'd be much more value to have more nuanced data here so we can understand at a higher resolution level, what social determinants are driving exposure and what we can do about that from an intervention perspective. The second area I'm not going to say a lot about. I think it's self-evident, but we need standards. I was actually quite surprised by the lack of standardization in this space in terms of how assays are performed, how they're reported, even changing equipment, certainly looking across labs, sometimes using the same assay was very difficult to compare the results. And so there's a lot of work that has to be done. This was a major focus of what we're proposing in this network, is to develop standards, some of which we already have, and in many cases isn't developing new standards, it's identifying existing standards and incorporating them into the processes that are occurring within laboratories and within surveillance networks. The next area is extended data linkage. So this sort of follows the example of social determinants of health data, but really saying, wouldn't it be great if we had much larger linkage? So this was a problem throughout, and consistently a problem in Canada, is we have public health data, we have clinical data, we have laboratory data. It's often quite difficult to bring those together in anything approaching a useful time frame for public health surveillance. So we think we have a strategy that will work here. Again, it's this federated approach within provinces and territories, and a big part of what we're proposing is going to be, again, to build on this example of what I call a data governance framework, to clarify what are the legal and ethical frameworks that allow us to do this. For the most part, people don't let this happen, not because it's not legal, but because they're not sure. And so they take a risk-averse strategy or stance, and it doesn't happen. So the idea here is really to be quite clear about this process, ensure that that linkage occurs across health services data, laboratory data, clinical data, and public health records, and create a process for doing that in a distributed way, but do it consistently so that it can be rolled up into a national picture. And this is just an example. I know there's a lot of interest here and generally in federated analysis, but for those of you that aren't aware, it's a fairly rapidly advancing technical area. This example shows for hospitals from a project that we did in Quebec with 8 different hospitals that did a federated strategy for looking at data. And the idea is that at each site where you're collecting data, the data are there, everybody formats and structures their data in a similar way, and then the data do not actually leave. What happens is the user at the far right will either have a query or analysis that has to, of course, be pre-approved through a governance model. That's deployed through some central hub, sent out to the different sites. The analyses are done. Sometimes they're an iterative process, sometimes it's a one-off, but all that comes back to you are the results, then get assembled and returned. So it's technically feasible. It's been done and is being done in many places. The challenge, I think, in practice is having, as I said, the governance model and the processes that allow you to do this and do it in an efficient way at scale. And the final area is systematic data management analysis. So, it's, I think, pretty clear for most people that have worked in public health that there's a need to modernize data infrastructure. And so really what we've identified here is a strategy that is going to be quite consistent. This is a bit of a busy slide, but what we're showing is different sites that are doing serosurveillance, essentially. Some have more capacity for testing and some have to ship their results. But what's unique here is that each site is doing their collection and then sampling. And here, as you can see, we've got a link back to do sampling guidance to each site. So we don't want to have just sort of hard-coded or consistent sampling strategies. We want to have sampling that's adaptive. So as we see issues or challenges in some subpopulations, we can change the sampling strategy to better understand that. And then, of course, testing and results can be, and analysis can be done on site in a consistent way, and then those results can be centralized and communicated. So that's the strategy that we're proposing. Okay, so just to bring things to a close here then, where's the Public Health Agency going? So at a federal level, the next steps for this vision more generally, now I'm talking not just serosurveillance now, but in general, knowledge mobilization is what we call it in Canada. The communication of these results has already begun. We've had some presentations, and we're preparing manuscripts that will be made available to show more carefully the process we went through and go into the details of some of these challenges and opportunities. The agency itself, we've had a new government at the federal level in Canada, and some changes in the Public Health Agency of Canada, but the process is now underway of aligning planning and operations with this vision. But as I mentioned, it's not just meant at the federal level to be a vision, it's also for all of the provinces and territories. And so, in fact, this is what I've been doing and will continue to do for the next few months, is engage with many of the partners in provinces and territories to work with them to understand how they can align their surveillance plans and activities with different elements of the vision. And really what we mean there is to get into those opportunities I had and try and make sure that we have the federal government, the provincial entities, and the local or municipal governments all sort of triangulating on the same issues to try and really move those forward. And then we do have formal processes in Canada. They're called the Federal Provincial Territorial Tables, which is where really decisions and resources are allocated. And so we're tying this work in with those groups to make sure that not only is it sort of goodwill, but also resources are available to make it happen. And the last thing I just want to talk about are some of my reflections. I mean, this has been a bit of a journey, I would say, understanding how surveillance works or doesn't work at many levels within a country. And you know, I think it's clear, it's probably clear to you from this presentation, if not from your experience, that surveillance systems for the most part and programs remain what we call siloed. So if I go back to those 63 different systems at the federal level we have in Canada, they're all organized around diseases, and that's from a historical perspective. And that's not entirely inappropriate, but if you think about modern technologies, it's very hard to advance them because every sort of silo or program has to identify what are the innovations, how do I incorporate it, how do I get the technology, how do I hire the staff, and that's just not the way that modern digital public health should work. We need to have common shared platforms. That goes back, I think, a bit to that WHO study I mentioned in our system of systems framework as well, so that we can bring those kind of platforms and technologies into public health organizations and use them in a way effectively across multiple programs of surveillance. And that obviously requires digital transformation, which is difficult. It requires clarity of purpose, so understanding what are we going to surveil and what are the best ways to surveil that. And you know, there are examples. Here's an analysis that we did at one point, but there are many examples like these where you can look at different approaches to surveillance, which you see in the left column, try and understand their characteristics in relation to certain types of conditions or diseases, and really back that out and have a bit of an architecture almost for public health surveillance infrastructure. And I think that's actually lacking right now, certainly in our country, and I have not really seen that very well articulated on a global scale. So, you know, doing that's going to require obviously some leadership, and then ultimately to put that in place is culture change. And that's something I certainly learned from working in our Federal Public Health Agency is, you know, often, and certainly when I first got into informatics, I thought of it as a technical domain. And there are many technical aspects, but when you really want that technical change to make a change in the real world, the technology is really secondary. It's really about the social and cultural environment and how do you make that change, and how do you get people to understand the value of that change and buy into it. And that can be quite challenging in a public health context to effectively communicate why should people change what they're doing, to adopt a new technology or change how they're working to make it better not only for them, but also the entire public health enterprise. But if we can do that, then I think we can move towards this kind of systems of systems, collaborative environment that I've talked about, which is a value proposition for everybody, and we really can move things forward. So I'll close with that. I hope that it's been a useful overview of both the vision, serosurveillance, and then how these things can move forward. As I mentioned, this report's available online, and if anybody's interested in the data that we have in the CITF data bank, which is freely available internationally and even for commercial use as well, here's the URL, and I'd be delighted to hear from you if you have any questions. Thank you very much.